Uh, Thank you for attending this week's Health Informatics Seminar. I'm David Potenziani of UNC, and I'll play the role of host for our webinar. And do please remember that today's meeting is being recorded, we hope, and we will hear from our speaker and then have some time for Q&A, where you should feel free to unmute yourself if you're online, or let us know if you're in the room with me, to go ahead and share your thoughts, pose a question, and we'll have a conversation. So today we're joined by Dr. Susan White, who is the Ohio State University's Wexner Medical Center's first Chief Data and Analytics Officer. She leads the Analytics Center of Excellence. Today, she is going to discuss how analytics is transforming healthcare by integrating data-driven decision-making at the bedside, focusing on healthcare data quality, security, the challenges of data silos, visualizing information for frontline clinicians and executives, and finally, the importance of multidisciplinary collaboration. Dr. White.
Thank you. Thanks, everyone. I'm happy and honored to be invited to talk to you all today, and hope you'll find it interesting. I'll end up probably spending about half the time giving you an overview, and hopefully, not hopefully, we will have lots of times for questions. So I have my chat up. I am not the best at watching the chat while I present, but I will certainly try. So one of the challenges. So as David mentioned, I'm the Chief Data Analytics Officer for our medical center. So we have 7 hospitals, a large physician practice, and we're pretty much dead center in Ohio, if you know where Columbus is. In addition to a hospital, we also have a football team, which you may or may not be familiar with. I have to do that. It's part of my contract. So I want to talk a little bit about some of the opportunities and challenges when you're bringing health care analytics to clinicians and operators, or even just summarizing administrative data around healthcare, how to meet the needs of various audiences. I'm going to give you a little bit of a rundown about how we solve that problem here at Ohio State with my team. And then I have a couple of case studies. I'll probably cut those short just to leave a little bit more time for questions and answers. But let's go ahead and get started. So when we think about the types of data that we're collecting in the healthcare setting in general, we've got the EHR with the clinical records, right? And so we happen to be an Epic shop, so that's not the only application, but that is what we happen to use here. You have patient demographics, social determinants of health, gender, age, other smoking, other habits that may impact health, and administrative data. We have data around how quickly we can turn our beds over, how quickly we can turn our operating rooms over between surgeries. How long patients stay in the hospital, where they're going to go after the hospital, how they get in, can we transfer patients in? So a lot of these are three of the most common data sources. And some of the challenges here is, we want the data to be accurate and complete. One of the issues that we run across quite often is we're using data for a secondary use. So data may have been collected, say I'm treating a patient, I'm writing down their history and physical, thinking about what sort of comorbid conditions might they have. Are they diabetic, or are they asthmatic? And then I'm going to go ahead and kind of do a workup and see what symptoms they may have. That data is all collected primarily to treat the patient. And yet we use it very much, especially in the US, for a secondary use. So we may use it for billing. We may use it for quality measurement. And as we do that, we have to be very mindful that the data we're using wasn't collected for the primary reason that we're using it for. We have to worry about data security and compliance. So we have HIPAA. So often, so as an academic medical center, and many of you are from academic medical centers with hospitals right on your campus. So I've got campus, I've got the hospitals, I've got the engineering department that would love to do modeling on our data, maybe do some simulations or throughput analysis. We have to be very careful because of HIPAA. We can't release identifiable data for that reason. So we have to be very, very careful with that data and security. We like every industry in the world now are subject to hacking and all kinds of crazy things happening. So we have to keep this secure and running. I apologize. I need to put myself on Do Not Disturb. A message may come up, but just ignore it. So healthcare data is also dynamic. It moves. So we've got technology, different ways of collecting data. I may have collected basic vital signs in one way, I'm written down at one point and then automatically feeding. And then maybe we're now doing some ambient listening. So using AI to listen to what the patient's saying and interpreting that into a record. We've got changing clinical practices. I have to we have to keep track of more complex treatments, dosages of drugs, interactions of drugs, the regulations, more reporting causes difficulty in healthcare. Maybe I'm not collecting the data element that I need to report, so I have to start collecting that so that I can report it. And the need for adaptable analytics. That's a very simple use case for adaptable analytics is, having the data sitting on a dashboard and the administrator's desk is no longer good enough. It's got to be on their phone. It's got to be refreshed very quickly. So very dynamic in nature. The other challenge that we deal with, and I think this is not a healthcare specific thing, but it's very much present in healthcare, is data silos. So I have systems that don't talk to each other. I have people should only, because of HIPAA, researchers or administrators or clinicians should only get the minimum necessary data they need to do their job. We've got vendor lock-in. So I've got a vendor that maybe has their own reporting and doesn't think we would ever need any other reporting for any other reason. And so therefore they've kind of locked us in. I'm going to close that window. And therefore they've kind of locked us in. And so we end up doing things which I lovingly call sneaker net. We take a report out of one system, we put it into another system so we can combine the data together. And so that all causes some challenges, many that we get through, but many challenges. Just some examples of data silos. Believe it or not, there is still some manual collection of data. Right now, we have a initiative going on around patient falls. And so with that, there's a rounding component. And so nurses, they would normally abstract into some sort of paper or spreadsheet. We now have them putting it into a system called RedCap, which we can then scrape and put into dashboards. But there's still some manual processing going on, believe it or not. And so because of all these challenges, we have incomplete data. We may be delayed in our decision making. The redundant test is a real thing. If I can't have the results of a test, patients transferring in, I don't have the results of the test from the previous admission, I then have to repeat perhaps a very expensive diagnostic test. And so all in all, not great impacts on some of the siloing that happens. All in all, we're able to kind of get through some of those and be able to find some solutions. And then we come across sort of the next issue that we're faced with, and that's tailoring either data models or visualizations for a very diverse audience. And so we're looking at clinicians, and clinicians need data real time. They need data fed to them within their workflow. So they can't be running outside or running to another computer to check some dashboard or something. They have to have that data right in ideally right in the EHR, so that they can look at compare this patient to other patients, or look at trends in the vitals and see what's going on with their patients. For executives or administrators, next day data is probably okay. They have a higher level of focus. They want to be at that 10,000-foot level. They want to know in general what's happening with patients. And so trying to meet both of these needs is very challenging. But again, that's why it's fun to work in healthcare, because we have these challenges. And so we try to keep these very simple goals in front of us when we're creating any or presenting any data to folks. We want to keep it as simple as possible. Get it as close to the action. I always tell my team, nothing we create, it's going to answer every question the end user has. But if I can get them to maybe the second or third of the 5 whys, I feel like it's a win. And so we want to be as actionable as possible. We don't want to make them think too hard when looking at the data. We want to use color and that sort of thing to try to positioning all those tools we have. And we want to present at the right place at the right time. And so all of those sort of help us steer how to present the data. When we're thinking about data that might go to a clinical leader or an administrative leader, we've got to be careful we're focusing on the right level of grain. No chief operating officer wants a listing of all the patients that are in a particular unit and their blood pressure or something like that. They want to average. They want more distilled down data or aggregated up data. So let's talk a little bit. I talked a lot about challenges, but let's talk a little bit about how we've addressed those challenges, at least here at OSU. I have a team called the Analytics Center of Excellence. And so we are, my team itself is multidisciplinary in nature. We have data engineers. I have a couple of clinicians. I have public health folks, people who have grown up in informatics and billing and coding, rev cycle experts. So it's a pretty wide, diverse. There's people who are statisticians like me. By training, I'm a statistician. So I have a data science team. And we try to combine all those skills. But again, we're wrangling a ton of different data sources. And so the question that I often answer is, so you have an analytics center. Is everything then centralized? And the answer is no, everything is not centralized. And so the reason, this kind of gives you pros and cons on centralizing the analytics effort. The advantages is it's centralized, right? I can control it. And as an admitted control freak, that's good. I can control all of it. The disadvantage is it's difficult to scale. You can only do so much in a centralized team before you totally outgrow the space and can't serve everyone. And so we end up with those data silos popping up, or individual analytics teams, sort of shadow analytics, if you will, popping up because the centralized area can't serve the need. And so we opted to go with a what's called a franchise model. And I'll talk a little bit about that. But basically, it's a balance between centralization and total federated efforts. And so our Analytics Center of Excellence standardizes the tools. We allow we have a standard dashboard template, but we do allow some customization by individual departments. We're able to be full service where it's needed, and then sometimes for some groups, all we do is data curation. It helps promote collaboration. A lot of times when you have these small pockets of reporting and analytics, informatics activity going on, there's no mentorship. there's no career path, and there's no, peer to sort of say, hey, have you encountered this, or where can I find this data? Those kinds of issues. And as it grows, we can scale up in the hub, or we can add new spokes, however we want to do that. So our model ends up looking kind of like this. And I shaded this according to how much support we provide to each of these. So for our quality team, we supply everything from data curation, data collection, even in the Falls example I used, all the way to dashboard production. For pharmacy, their analysts are actually pharmacists. So there's no way that we in the center, in the hub, could possibly provide that level of subject matter expertise that's required to do some of the analytics they need to do. And so we provide data curation. So really, we're giving them data engineering support and providing them with data products that they can then use for their analysis. So it's a huge, it's a wide continuum. And the franchise word kind of resonates, at least when I explain to people what our model is, because you can have sort of the corporate-owned franchise, or you could have the individual-owned franchise. The corporate-owned franchise, I'm supplying the materials, I'm supplying the fryer, if it's McDonald's or it's Wendy's, whatever your choice of fast food is. I'm supplying everything from the corporate area. Individual, they're buying, and their labeling looks the same, right? If you buy fries from the independent franchise, it's going to be the same as a corporate owned, same packaging, hopefully same taste, same everything, but the structure is sort of different, and the way it's delivered is different. And so that's kind of the way we've tried to get this multidisciplinary approach. And we're providing, this kind of gives you an idea of our footprint. We have 5,000 active users now. We are, the medical center employs about 33, I think, thousand people now. I hesitate because we're opening a new hospital in a couple months, so we brought on some new people. So we're in the 30s. About half of those I would expect to be able to want to use some sort of reporting tool or data aggregation. So we're growing. And one of the ways that we partnership is through business domains. And so all of our work is sort of divvied up into these 15 domains. There's actually a 16th domain that kind of encompasses all of them. And that's where our service line work happens, because they would draw from many domains. That's also where our nursing domain lives, because they have all of these, or not all, but many of these components also. And within each of these domains, we have clinicians, business people, and the technical people all coming to the same meeting. We use an agile approach, so either bi-weekly or every 3 weeks, depending on the domain. But this is sort of gives you an idea of how we've taken this multidisciplinary approach. We've got our team members here, which are basically happening in each of the domains. This one has to be surgery and procedures. We've got an analyst. We'll have an analyst come from the EHR team, or for us, as I said, it's Epic. We'll have an informatics expert that will help us with, how's the data collected? Where is it collected? Could we collect more, and where in the workflow? We have a surgeon, perioperative leader, which is sort of an administrative person around surgical scheduling, and then OR prep and staffing, and then our scheduler. So we take those business, we say business, but they're very often clinicians in our work setting. And so when we bring it all together, we're able to create, I think, products that are fairly relevant and useful. I'm going to show you a couple of those, and then, I'm sorry, I should speak to the prioritization. So as you might imagine, the more data that we supply to people, the more reports and information that we supply to the business, the more they want. And the old adage, if you build it, they will come, is and force multiplier here. But what is really good, and what this diagram is telling you, is that we're able to prioritize about 90% of the work within those domains. So the surgical and procedure business is deciding what we should do next in terms of content. About 10 of it will go to a prioritization committee that we have in place. We have a data analytics governance council, which is a C-suite level council. Honestly, we've not had a project come there in the last year. So it's very rare a project gets to that level. But I'm very proud of the fact that the domains function in such a way that we're able to take what the clinical and business owners want and prioritize in that manner. I'm just gonna run through a couple of case studies to kind of show you how we try to meet everyone's needs or as best we can. So one of these is about CLABSI reduction, and I'm guessing there's some clinical people on the phone. I'm guessing there's some people that aren't like me. So just to let you know, CLABSI is a central line associated bloodstream infection. It's a quality metric that's measured by NHSN, which is a national level group. It's a quality measure that CMS uses for Medicare. It's also included in most of our value-based purchasing contracts, so it's an important quality metric that we want to do well on. I included a link so you can learn more about it. So why do we care about our CLABSI rate? This is data that I took from, this is public data, so there's nothing secret here. This is our hospital's rate, and it's per line days. So the line days, so the number of infections per line days, I think it's per 1,000 line days. And so our rate, and this is an observed to an expected rate, so it is somewhat risk adjusted in a crude way. Our rate's 0.878. One of our competitors, which is literally up the street, is at 0.582. They do better than the national benchmark. One of our other competitors is actually doing a little worse than us, but we'd certainly rather be closer to our better competitor. And so that's why we chose this to be a quality initiative for fiscal 2025, which we just finished in June. We're continuing to work on it, so it actually carried over to this year too. So this is what was going on and what led us to want to pursue this as a quality metric. The numbers you see here are not going to match the numbers that are from the Medicare website. That's because there's a different time period. And also their metric only includes certain ICUs and certain other areas. Our assumption, and I think it's a decent one, is that if we're high here, we're probably high everywhere. So we chose to tackle CLABSI in its entirety. We saw this lift, and so we took a couple of tacks at this. We have working with our clinical nursing and physicians, infectious disease docs, there were 18 process metrics that we track on a daily basis. And this is sort of an administrative view I'm showing you here, showing this is a product that we call Metric HQ. It does hold 440, I think now, metrics tracked on a daily basis. And so we're looking at CLABSI volume as well as the rate. When we have a CLABSI in some settings can be very low frequency. So, and sometimes counting, although I'm not a fan of it, counting the volume resonates with certain people. We follow the rate, which I think is more important because the denominator tells you how many times it could happen with the line days. And then we can wash where the port, and that's called CHD bathing. I'm I'm forgetting what CHD stands for. It's a chemical that they wash it with. So we want this to be a high compliance rate. Our goal is 90. You can see here, our goal for the CLABSI is 0.79. This is the line days. So if we reduce the number of times an infection could occur, that's a good way to reduce too. Days since last CLABSI, everybody always wants to know days since last bad event. And then the central line volume. So this is a snapshot in time. How many central lines do I have at midnight? And so we measure these. These are open to all employees at the medical center. There's also a weekly huddle, and I just finished the weekly huddle about an hour ago, where we go through and review the root cause of any infections that might have happened and look at these results. The challenge is the top graph here is sort of looking at that CHD treatment compliance by business unit. So I can see where it's high, where it's low, where it's getting better. So in here, south, it's getting better. East is getting a little worse. North is, west is inconsistent. So I can see all those from the spark line, but that doesn't help the clinician at the front line. And so within our EHR, we have this report at the bottom here that I have. And basically this is for the whole house, but you could do it for a particular unit, and the nurse manager can say, oh, I have 10 people in beds with a central line. 8 of those people might need CHD treatment. Some of them may have refused it, and some of them might need a dressing change. And then these numbers right here, you're actually able to click on them, and it'll go right to the patient so they can see the list of patients that need to be intervened on. They can contact the nurse, or we have PCAs for the patient care associates, which are, sort of nurse helpers. They can go in and actually act and take care of it at the bedside. So this is what I mean by the difference of having the two audiences. I have the administrators that want to make sure stuff's happening and the trending is good. And then I have the frontline people that really need to understand where they need to act. And so this supplies, so we have to supply data to both in both venues. So what? Well, the so what is really good. The so what is we've been able to get, this is kind of where that last here's where that last graph line ended. And you can see as we started our initiative, we've been able to get a shift in the process. So we have enough lines, enough points under the line here to say that we actually have a good shift. It's not zero. It's unlikely it's going to be non-zero. Bad things are going to happen, but it's definitely shifted down. So it's been good work. I'm going to give you one more example and then we can wrap. This is looking at operating room efficiency. And so there's a number of, so the operating room in a hospital is, or in any healthcare setting, is the most expensive resource. And so you want to make sure that you're being good stewards of that resource. And so we have a number of metrics that we measure here. They call this the Periop 6-pack. So we look at how often our ORs are used, our case volume according to budget, case hours, first case on time. Am I starting that first case on time? If I don't, that throws off my whole day, right? So I could end up paying overtime. I have unhappy surgeons, I have unhappy patients, and I start the day off kind of on the bad foot. That's the first, this is the one I'm going to drill into a little bit more. We look at our sterile supply accuracy. We want this to be, you can see the target here is 98%, and we're getting there, getting very close. And then median turnover time, our goal is 39 minutes. We're in 30 minutes, which is really good. So median turnover time means one patient surgery wheels go out. How long is it before the next patient's wheels can come in? So we say wheels out to wheels in. And you can see we've used, to try to lighten up the cognitive load on here, we've used color, we've used shape. Also notice this is not a traditional red, yellow, green kind of color palette. We used orange, gray, and blue. That's colorblind friendly. You would be maybe you wouldn't, but I was surprised at how many surgeons are colorblind. And so the default on this one is the colorblind palette. That we have the trigger, we have a switch that you can turn on and off colorblind on the others, but this one, the default is the colorblind palette. But we found that if I want to, say I want to take a look at this first case on time starts, and I'm going to dig into this particular venue. And what we want to know is, so they're not even batting, 500, like they're 44% on time starts. So why is that happening? Well, within the, what we're able to do is get to that level of granularity to really take action. And we're able to see, which day of the week. So it looks like Tuesdays are pretty bad for them, Wednesdays, or excuse me, Fridays also. And what's the cause? What's the delay type? And we can see here that almost half of the delays are surgeon delays. Some patient delays, and that could be patient not prepped, patient no showing, any number of patient or patient has a fever, any number of things. But this physician is really where we can act, and we can have the leader of that pavilion act. And so these rows, I blanked out the surgeon's name, but each of these rows is a surgeon, and you see the key down here. Orange is how often they're on time, and blue is the proportion where there is a delay. So my first surgeon, which is my surgeon with the most cases, or tied for the most cases, if I look over here, 6 of their 11 cases were delayed for a total of 85 minutes. This surgeon here is on time, it's delayed 2/3 of the time. To make that insult to injury, every time they're delayed, it's long. So it's about 45 minutes delay, between 40 and 45 minutes delay each time that happens. So now with this is very actionable. It has the insights. The leader of the pavilion, the surgical pavilion, can go talk to them and figure out what's going on. Why are you late? Should we not schedule you first? Any number of issues. What's interesting about this particular use case is this pie here. I'm generally not a fan of pie, but the docs like this, so I went with it. But the slices of this pie, I'm going to show you in fiscal 19, the biggest slice of the pie, and these are just looking at the same month going back, the biggest piece of the pie was unspecified. We made a concerted effort with the clinicians and the leaders in the OR. Hey, we can't do anything about this if you don't tell us why there's a delay. And so they were just putting other or unspecified, or just putting in some free form text. Took us a few years. We got it better. Finally, 6 years later, and this is true of almost all the pavilions, the unspecified is now a pretty small slice. So we can't act on it. If we don't measure it and we can't get the data, then we can't really act on it. And so this was an example where the operators actually helped us out by giving us the better data. I have a few other examples I can go through, but I'm more than happy to break now if anybody has any questions or want to do a discussion on kind of some of the issues around bringing data to the bedside or to the desk side, depending on which phenotype of person it is.
Well, thank you. That was very interesting. Let me start you off. So I've inflicted this thought on many students, that the greatest gap in understanding data is the distance between the screen and the back of the chair. And you look like you have approached this with some specific steps involved in creating data visualizations. Would you characterize your approach in an organizational sense as a shared culture of data use?
Yes, I mean, I think if I think about our culture from, if I think about us back in, so my group came into existence right before COVID, right? Everyone marks time that way, right? So my last meeting in person was when we met with the consultants and said, hey, you guys need to set up some sort of centralized entity. Um, and, um, and at that point, when I look then and I look until now, we had a lot of changes in leadership, clinical as well as administrative, that drove us to be a far more data-driven culture. I will say that I think, you know, COVID was an awful time, but with all the focus on counting, predicting, how many beds do I have? How many beds am I going to have tomorrow? How many patients do I have in isolation? That made our whole house very, very focused on data. And so delivering those very sort of basic blocking and tackling statistics became very, and looking at those every morning became a good habit. And so I think we've evolved into a very data-driven organization at that point for necessity, and then we've been able to scale it. So I think I think, Dave, I would say yes, David. We are very data-driven, and they're data hungry. We our list, and we use Jira for our project management. Our backlog is insane. So yeah.
Thank you. We have a question from Professor Swain.
Yes, I need to go back, Dr. White, when you, the only time you mentioned AI, and it just perked me up because I'm like, what did she say? That you were using AI for ambient listening.
Yes.
Well, that doesn't sound nice. I mean, that's not HIPAA, but could you explain more and the value of that?
Absolutely, absolutely. So, in our clinics, we do use Epic functionality. They've worked with Microsoft, I think, or Dragon, which I think Microsoft might own. I'm not good at who owns who. It's a Russian stacking dolls, right? We use that functionality in our clinics. And so the way that it works is the clinician says to the patient, do you mind if I I don't know if they say record or not, but they say, do you mind if I use the ambient listening for your visit? And then the patient consents to it. And then it's essentially in an all-in-one, or it looks like a phone. They turn it on. And then the AI functionality is able to extract the clinically relevant pieces of the discussion. It's sophisticated enough that, like, I don't know, if you ask the patient about their vacation, how was your vacation? It was great. I went to the beach, and da, da, da. None of that shows up. None of that shows up in the medical record. And then after the visit is complete, they turn it off. And then the physician then will go through and validate the documentation or the notes, essentially, for the visit. So this has saved us a tremendous amount of time. The clinicians are saving, it may not sound like a lot, but they're saving like 5 to 10 minutes per visit, which cuts down on their pajama time, which is, when they're working, in their PJs. I think even more important, the feedback that we are getting from our patients is very positive. There are patients that don't want it, and they'll say, no, I don't want to do it, which is fine. But for the patients that do consent and we use the tool, they love it because the clinician isn't sitting at the computer typing, looking at the screen. They're engaging with them. They're like actively listening to them, and not just sort of like typing like which sometimes I do with my kids, but I assure them I'm listening. but people really are listening, and we've scaled it to all of our clinics, and I believe we either are or will very soon scale to the emergency department too. But again, it does require that consent before we turn the device on.
It sounds like an effective thing to do. Thank you very much.
Let me give you one example of AI where it's not so great. How AI not so great? How could that be? And it's in so those of you who go to a provider that has Epic, you might have a MyChart account. And so the MyChart account lets you email your doc, right? You can say, hey, you gave me this medicine and I forgot how to take it. So can you remind me? Whatever. I always ask them dumb things. Or, hey, here's a picture of this thing is on my leg. Is that okay? Whatever. What there's an AI functionality that we turned on for a while that would automatically compose a proposed response to that to the patient. And all the doc had to do was read it and go, yeah, that looks cool. That looks good. Go ahead and send. What the clinicians found is by the time they let that happen, looked at it, read it, edited it, they could have typed a message. So we turned that off. It was a AI functionality it just got in the way of the workflow. So they're not all fantastic, but certainly the ambient listening has been very successful. We have a couple of articles out there about it. If you Google Ohio State Medical Center and AI or ambient listening, you might be able to find them.
Well, that's one thing I would complain when they're always looking at the computer. But I had surgery recently and he was trained at Ohio State. So he was very good bedside.
Well, excellent. Glad to hear that.
Well, let me build on that question. AI is useful for a whole host of things. And I am thinking in terms of, well, could it be harnessed to operationalize your analytics approach? Because quite often that's the most creative area to be able to deliver through a visual interface information that comes from so many different kinds of sources.
Yeah, that's a great point. My team's using we have OpenAI. I think we're using the OpenAI tools right now. But we're using it for two reasons. One, it will help you pick out the best. It can help you pick out the optimal visualization to use, right? If I have this kind of data, how should I display it, right? So it'll do that. That's kind of like a no-brainer. But what we are using it for that's really neat is two applications. One is for my team creating metadata. And so the people hate, myself included, the last thing I want to do is document what I just did. Right? I just forget it. I don't want to do it. And so we have a SharePoint site, and in that SharePoint site we have hundreds of dashboards, but we've created this assistant that says, hey, where can I find wait times for surgery or turnover times for the OR, whatever, the one we looked at, and it'll kick them up and provide it to the user. But it'll only do that if it's properly documented on our site. So then the agent can go, it never gets into the vector database to be searched if it's not there, right? You can't make stuff up. We're using that to capture metadata. So we'll put in a picture of the dashboard and it'll tell us what KPIs are there, what comparisons might be there, what filters are available. So we're using that to help us go a little faster. So
let me ask, as you look at this approach and the work you've done, the development you've accomplished, what do you see as the biggest challenge in looking at the future within your current realm of operation? Because I have a follow-on for that too.
Yeah. I think the biggest challenge is to do more of what I showed you with CLABSI, where I have that dual view. I have the actionable view sitting right there, and I'm measuring the exact same metrics at arm's length for the administrator. So they have a shared, there's a source of truth, there's a shared understanding, this is what's going on. A lot of times, some of the canned metrics that are in some of the tools, some of the EHR tools, are not defined in a way that's meaningful for your particular site. And so redefining those requires a build on both sides. It requires a build inside the EHR and outside, and to keep those in sync. So because you want one single source of truth for what's an infection or what's not an infection, right? But you have to allow alternate lenses to come into that single source of truth at different granularity and from different tools. So I think that's kind of the hardest thing, is to be able to serve all the masters. I think that's the most challenging.
So let me take a step back here and ask you this. You didn't quite explain how your center came about.
Mm.
Uh, what was the approach? Was it external funding, internal funding? What did you have to do to actually convince people this was a good thing?
It's a great question. I didn't include that slide in this presentation, but I have one that sort of takes us through the timeline. So you'll have to envision it for a hot second. But we, at one point, I was leading a very small analytics team in our cancer hospital, and we were supporting we started sort of trying to scale and couldn't. And our CFO at the time brought in a consulting firm to sort of assess our analytic ability and figure out how we could move to the next level. The result of that was to put together this analytics center of excellence. There's a but, but do it with existing staff. Okay. So, so I took about half of my cancer team. There was an analytics team within our strategy component. So they came along. There was a business intelligence, very small business intelligence team in our IT. So they came along. So we ended up with about, I would say, about 15 to 20 people that I wasn't very popular because I just sort of carved them out of other people's teams and put them all together. The only advantage I had was timing. And that's why I say that, COVID happening then, I had very little friction when I tried to do that, because everybody knew we had to get smarter, faster. And so it's kind of like I fell into a good situation. As we matured, so we happened to be a Tableau shop. And so as we matured, we brought on our quality department had an analytics team, so they came in. And so as we started proving ourselves, people who had federated analytics teams said, I'll let my team come over with you guys. I think I like what you're doing. I feel like you're going to support me, right? And so I'm going to give up a little bit of control, and with giving up a little, I see what you did with quality. When they gave up a little control, they got a whole lot more content, right? And so what we're able to do is I actually have data engineers on my team. So I can let the analysts be analysts. They don't wrangle. My engineers wrangle. But they work close enough with the analyst that it's not like you're making an IT request for a data set, you're getting it back and you're going, that's not what I wanted. Let me do that again, right? So, and so it's been an incremental build. The only new hires we brought in, last year, we brought in four additional data engineers, so that we could support people like the pharmacy group, because I didn't bring any staff in from them, but had to support them. So we sort of brought in a few, but we hired very few people. And now I have a team that's 60 in force. And, I showed you the footprint of Tableau that we have. So we have a lot of users, a lot of people subscribing. Subscription to a Tableau dashboard means that lots of times every morning, they can set the cadence, but some of them every morning they get an email that has like a snapshot. We also use a tool that Tableau has called Pulse, which is a cloud-based tool that gives them a snapshot of a KPI and then allows them to kind of drill on it. So kind of organic growth, sort of like thou shalt make a center, and then some organic growth, if you will.
So it sounds like there's a couple of things going on here. Part of this is you're delivering some value that people hadn't seen before, or hadn't seen enough, and they like that. And so that's a, sort of a call and response kind of approach. But you also have a structural approach in a way when you're talking about being able to bring in people from organizational components that already exist and sort of imbue in them the values and the valuation of this approach. Now, all of that is just preface. Is this approach something that you could take on the road? You call this a franchise model, but Ray Kroc didn't become a zillionaire until he opened thousands of his restaurants.
Yeah.
Is this something that would be open for you to consider taking outside your current frame of reference?
Yeah, I believe so. And I think one of the places we're going to do it first. So probably most of you guys, most of the audience might not be aware that when a small hospital wants Epic, they often can't afford it. So they do something called Community Connect. So we have different service, they call them service areas. So we have different smaller hospitals that use our Epic instance, but they're not part of our hospital. And so that's our first place that we're going to start scaling, is to there. And then we'll see, it's a safe place, right? It's a safe place. Like I still can get a revenue stream. And then, so I think we're going to try it out and see if it actually will work.
So, I mean, it seems like this would be being able to describe this in a peer-reviewed journal would be an ideal way to get these ideas percolating across the sector. Is that in the works?
No, you know what? I did spend time on the academic side, but my academic time is not what I would like it to be. But I think you know, a journal that has some practitioner work in it is probably an interesting one to go with. And I think it's an innovative approach in that I didn't play a big game of Risk, right? The game Risk, where I'm like taking over territories, right? It was very much a support and a you know, a little bit of trust, but when you deliver, you can scale, right? And so that's really the key, is to be able to not go too fast, you know.
Okay. So one question here in the room. Hold on.
Hi, thank you. Really interesting presentation, and I appreciate that you spoke about, you know, using things in real time for clinicians as well as administrators who are maybe interested in the data outputs that might have different objectives. With that, I'm curious, in the case that you mentioned for CLABSI with you know, clinicians being able to click in real time and respond to patients, was there any time taken away, or how did you manage the time that might have been involved with data collection? Because I think as clinicians, we often want things to be more efficient, but it is often upon our broken backs of just
Yes.
adding more tasks. So I'm curious about that aspect.
Yeah, so true. And with the collapsing measures we're doing, that is already, the nurse is already documenting that they're either changing the dressing, because we want to like minimize dressing changes, but keep it clean. My understanding, I'm not an expert statistician, but I listen a lot. And so things like testing line patency, the CHD bathing, the dressing changes, those are already going to be in the documentation. They're already documented as the process of care. So there's no extra documentation there. I will give you one of the places where we're now working on falls. And with falls, we did have to add some documentation because we're using a different falls risk model than was sort of built in. And so I will tell you that quite often we will work very hard with the clinical experts to get a proxy measure that's already there, if we can. We may not get the perfect measure, but if we can get one that's going to be directionally true and not disrupt your workflow, that's the way we're going to go. So.
Okay. We're running out of time. Thank you. This has been very interesting.
Do we have her email address, David?
Oh, I'll put it in there.
We will in a moment.
And the reason I bring that up is to tell you about mobilizing computable biomedical knowledge with people at Michigan. You can get an article out faster and not feel like, you know, you've spent too much time the old way. So I'll
Oh,
send you
okay.
information. Yeah.
Thank you. I appreciate that. Yeah, I put my I went ahead and put my email in the chat. Always interested in learning. As I didn't mention it earlier, but I was on the academic side for quite a while, so I spent some time doing that. I sometimes am a frustrated academic in my role, but you know, administration is administration. It's okay. It's a living. No,
Great.
no,
It is the penance we pay.
yeah, that's right.
And you've really helped
right.
efficiency. Thank you so much, Dr. White.
Thank you very much.
Yeah, well, thanks for the opportunity, everyone. I really appreciate it. Bye-bye.